Thank you very much, Dr. Cam, for the kind and gracious introduction. I really appreciate it. Can you see my screen okay?
We can.
Okay, thank you. I was asked this morning to give an overview of our experience with VHL over the past 38 years now. And I mentioned to my wife last night, I said, honey, you know, I'm speaking at this VHL symposium. And I said, you know, I have a lot of friends and incredibly accomplished colleagues who are in this group. I said, you know, many from Canada have already been mentioned, really established experts. I said, what am I going to be able to tell them they don't know? And she said, honey, you'll think of something. Anyway, so I thought what I'd do is sort of go over our experience with VHL, von Hippel-Lindau. And I guess whenever I think about this disease, I think about these wonderful, brave patients that we have had the honor to work with over these last, I guess now 38 years. And we have learned so much from these individuals, and we continue to learn so much from these individuals. Now, our work started, and, you know, I'm giving this talk, but I worked with so many colleagues, and so many people from around the world have made such significant contributions. And we're going to hear from so many of them during this meeting, which I'm so excited to attend and hear their work. And a number of things I'm going to talk about, you'll hear in much greater detail as the meeting unfolds. But we started our effort in the early 1980s with my wonderful long-term colleague, Burton Sabar. And we knew that we started with sporadic kidney cancer, and patients with kidney cancer at the time who came to someone like me, a urologic surgeon, you know, with a localized tumor, we could take that tumor out and give those patients a 95% 5-year survival, really better than that. But if patients came to us with advanced disease, you know, over 80% of them died within 24 months, and we had no effective forms of therapy whatsoever for those patients. So we started to work on kidney cancer, and we started with sporadic kidney cancer, and we had the kind of ambitious goal to find what we thought was the gene for kidney cancer. And we were seeing a lot of patients here. Was working with Steve Rosenberg on immunotherapy, and Dr. Rosenberg was doing IL-2 based therapy, and we had a whole lot of patients, and we were seeing these patients, and we had access to all these tumors that we took out surgically. And in the middle 1980s, Bert and I showed with Hiltrud Baruch, a wonderful colleague, showed that there was a consistent loss of the segment of the third chromosome, chromosome 3, in tumor tissue from patients with kidney cancer. And at the time, and I don't know how we sort of got the guts to do this, but we put in the discussion of that paper, which we published in Nature, and we were all happy about this, that we sort of predicted or thought that this work would indicate that in this area on chromosome 3, loss of a segment of chromosome 3 uncovered a kidney cancer disease gene at this location. And we put in there that we thought the function of a kidney cancer gene might be to enable the cell to respond appropriately to environmental stimuli. And who knew that we would be right about both? That the VHL gene would be in that location, and that the environmental stimuli would be oxygen. So we then started mapping, and I would take out tumors, and we kept mapping and mapping. And I can still remember, I can still feel that pain in my stomach. We worked and mapped for 2 or 3 years. And we looked in this region, and we were doing old school restriction, fragment length, polymorphism analysis, or RFLP analysis. this was 18 years before the human genome had been sequenced. There was no map. And we finally realized, we're in Bethesda, Maryland, that what we were looking for was somewhere, for example, between here and San Francisco, and we were looking for something in Kansas City, in a neighborhood, on the street, in a house, in a room, and we were looking for a light bulb in Kansas City. I'll never forget it. We kind of thought, oh my word, how are we, what we're going to, how are we ever going to do this? And we were lucky, as many people are, to have such a wonderful mentor, Dr. Al Knudsen. And Dr. Knudsen said to us, look, if you can identify a hereditary type of the disease you're working on, you could use the power of genetics to hopefully to identify a kidney cancer gene. So we then shifted gears and set up a program to study cancer families to identify kidney cancer genes. And our hope was that, that Knudsen's hypothesis would apply, and that a gene for this sporadic form of the kidney, the hereditary form of the kidney cancer, might be relevant to the sporadic non-inherited. Of course, that's not the case in a lot of situations, obviously, but everyone knows. You look at the hereditary breast cancer genes, they're not necessarily the genes for sporadic breast cancer, obviously, but we figured, well, maybe we could make progress there. So we set up a program to search for the clear cell kidney cancer gene. And we started by studying von Hippel-Lindau. Actually, we started by studying chromosome 3 translocation families, but there just weren't enough of them around. We knew that had been shown by the group in Boston, that translocation of the chromosome 3, you could get bilateral multifocal kidney tumors, but we couldn't get the families and we couldn't get enough patients. So we then flipped to studying von Hippel-Lindau. Of course, everyone here knows is a hereditary cancer syndrome and with tumors in both kidneys. And I've, most of my, certainly started my professional career, obviously, with my day job in the operating room as a surgeon. And over the years, have been blessed with a wonderful group of colleagues here at the NCI, from Carrie Robertson all the way down to Mac Walther, Gary Weiss, Richard Alexander, John Phillips, Peter Pinto, played a huge role. Gennady Bratislavsky was with us for a number of years and really ramped up our approach. Adam Metwally was with us for 6 years. Our current urologic oncologic surgeons are headed by Mark Ball and Sandeep Garan. And over the years, we have performed over 1,000 surgical procedures on these patients. And during this time also, this wasn't really as an afterthought, this was planned. We trained over 100 urologic oncologic surgeons in the surgical management as we've learned together. And they've played such a big role in what we've done and what we've learned and what we've experienced with these patients in the management of VHL-associated renal cell carcinoma and pheochromocytomas. And fortunately for us, over 95% of the trainees we trained since 1982 have gone into academic medicine, either in the US, we have a few in Canada, we're thrilled about, and 18 of those have become chairs. So they're training other urologic surgeons about the management of these patients. And we're really touched about that. This, of course, is primarily almost 100%, of course, clear cell kidney cancer. And over the years, we came to understand that these patients are at risk for developing up to 600 tumors per kidney and 1,300 cysts per kidney. And in the old days, when we started this work, people thought that the VHL kidney cancer, in my field certainly, VHL kidney cancer was not kind of a real cancer. It was sort of different than sporadic cancer. My field didn't understand the term lead time bias, and we know now, of course, that these are regular kidney cancers and that they can spread and they're aggressive cancers. We know that. And over the years, we've developed an approach of management of these patients. The first patient I saw with, we saw here at NCI with VHL kidney cancer. It was a patient who'd been operated on by an unbelievably distinguished and accomplished colleague at another major medical center in the US, and came to us with, if you want to say at the time, we'd say recurrent kidney cancer. And I looked that over and gee, you know, in my training and in our field, kidney cancer, you took out the kidney. And his was recurrent, and we had cancer in both kidneys. And I talked to a bunch of my colleagues here and everyone agreed that the way to manage this is to remove the kidneys. So I took a first patient, I took out both of his kidneys. And I'll never forget it as long as I live. I took him down to the front of the hospital at NIH and put him in a taxi cab to go to the airport to go back home up north. And I said to myself, you know, I'm never going to do this again unless I really, really, really have to. I said, they can fire me, but I'm going to start just taking out the tumors and not take out the whole kidneys. So we started doing partial nephrectomies on those patients, and we were operating, and then they, you know, they'd come back, they'd have more tumors, we're reoperating, and gee, you know, I can still remember the operation. It's funny, I can still see us in the room, and we were closing this patient. And I said to one of the fellows, one of the trainees, I said, we're going to have to start putting zippers in these patients. I said, you know, we have to operate on these people so much for these kidney cancers. And we then, with my colleague, Mac Walther, we then established an approach of doing active surveillance, not operating. And I will say this, in my field, this was not popular. First, not doing nephrectomies was not popular initially. Pete Marston, that's not the way you handle these patients. You take out their kidneys. But then when we said we were not going to operate on them until the tumors got to be a certain size, people said, look, son, that is not the way you handle cancer. You've been at NIH too long. They said, you know, these people are going to spread, they're going to die. And there was far more people disagreed with the approach than agreed with it. And I'll never forget it. I used to have nightmares. I can remember waking up at 3 a.m. and knowing that when I had clinic that day, I was going to go back to clinic and see patients with VHL, and they were going to come back with lung metastases. And we developed an approach of waiting until the largest tumor was 3 centimeters, at which time we would recommend surgical intervention. We operate. We've taken out as many as 94 tumors from a single kidney. However, to this date, we have not yet, now we may tomorrow, but we have not yet had a single patient develop metastatic disease when managed in this fashion. Now, some people refer to this as the NCI 3 centimeter rule. We don't call it a rule. We call it a guideline, a recommendation. And also whatever the surgeon, whatever he or she's comfortable with is our basic thinking. And also people can change, they can modify that. And if they're not comfortable with where the tumor is, maybe they're more worried about a central tumor than a peripheral one, fine. You know, we have zero tolerance for metastatic disease. So just do what you think's right. Also, if there are fast growth rates and you're worried about it, and you want to intervene earlier, absolutely. So we're still learning as we go. But basically, to this date, we've not yet had a single patient develop metastatic disease. What we do is in managing this fashion, but we're still learning. We're always open to modify how we think, of course. And so we follow growth rates on these tumors, and you can see here. And once the patient's tumor reaches this threshold, 3 centimeters, we recommend intervention. And over the years, recently, Mark Ball looked at this in a paper that was in JCO, and we showed that the average growth rate of a VHL-associated tumor is about, kidney tumor, is about 4 millimeters a year, 3.7, I guess. And that's faster than tumors, the genetically defined tumors like type 1 PAP with MET or chromophobe kidney cancer with folliculin, but not as fast as the clear cell kidney cancers in patients who have a germline pathogenic variation of BAP1. So okay, so that helps us. So, but we're continuing to learn a lot about how to manage these patients. And sometimes we see people with fast growth, they get slower and fast. And, we're getting smarter about how to manage these people and when to intervene. And our approach is always to be careful. Now, over the years, we've operated on we've done over 1,000 procedures in these brave, wonderful people with VHL. Last weekend, I was on call and I was rounding, and I Sunday morning was talking to a patient with VHL, and this patient, we sadly had to remove his solitary remaining kidney, do a completion nephrectomy. We'd just run out of space. And he told me, I said, I'm so sorry that we, had to do this. I said, but, we don't want this disease to spread. And he said, look, Dr. Linehan, he said, I've had 22 operations now. And he said, you did my first procedure in 1990. I said, 32 years ago. I said, yeah. And he said, my older brother had VHL, and they took out both of his kidneys, and he died 3 years later. And he said, you all have managed me, done all these things. I've had all these operations, but I'm still here. And I said, yeah, we want to get you a transplant, and hopefully, you'll have a long-term survival. But over the years, these are the number of procedures we've done on individual patients. And you can see here, we have 62 of these wonderful people, these brave patients, 62 who have had at least 4 kidney cancer surgeries. We've had 15 who've had 6 and 1 who had 11. So over the years, this has been our approach. As I mentioned, we went to partial nephrectomies, and then we went to active surveillance. And for years and years, we did, of course, what had been developed. And we learned from the great Canadian surgeon, the mentor to so many, Dr. Robson, who taught us how to manage patients with sporadic kidney cancer. And we did open partial nephrectomies on these patients. And then in about 2000, we decided, and that's really hard on these patients to do open operations. You have more scars, this, that, and the other. You go back in, those are big incisions. They're in the hospital a long time. So in 2000, we started doing laparoscopic partial nephrectomies. And then in 2007, with Peter Pinto, we did the first robotic partial nephrectomies of patients with multiple tumors, certainly the first year, and published that in European Urology, and also put out a video on that to help other individuals. And this is basically, for those of you who aren't surgeons, this is what we do. We developed an approach to enucleation about 1996, and we published on that. And this is how we enucleate robotically. And this was actually Peter Pinto doing a partial nephrectomy. And as you can see, we just go around the tumor there. We don't take very much normal parenchyma on these. And for VHL-associated kidney cancers over the years, this has worked with us very well. For other types of kidney cancer, such as hereditary papillary renal carcinoma, we do the same approach that we learned from VHL. And the same thing, same approach for those families and patients who have Birt-Hogg-Dubé. However, we do a very different approach for patients who have a different gene, fumarate hydratase, FH. For those patients with HLRCC, we do not do active surveillance in those patients. And in those patients, we don't do robotic surgery. We do open surgeries, and we go very wide because those tumors are different than VHL or HPRC or BHD in that they're very infiltrative into the renal parenchyma. Here, that's not the approach. Now, in spite of this effort over these years, we've, I'm sorry to say, had 53 patients who have developed metastatic renal cancer. So we're continuing to work on modifying what we do, how we think, earlier diagnosis, and of course, obviously, therapeutic approaches. Now, these patients also, as everyone knows, are at risk to develop pheochromocytomas, of course, which can be early onset multifocal extrarenal. We now use the term paraganglioma, obviously, to refer to pheochromocytomas that are outside the adrenal gland. And over the years, again, from these brave patients, we've learned so much also about pheochromocytomas. Over the years, we've described the pathologic phenotype. We've described the presence of pheochromocytomas in a number of places, including the bladder. Early on, we showed that genetically that the pheochromocytomas also are two hit, lose the second allele. We didn't know that at the time. And that it's the wild type allele that's lost, which is what you would expect. And then we showed, genotype, phenotype correlations. And one of the earliest we did this was done with Jody Moranchi, was first author on this paper, in which we showed that a genotype, phenotype correlation with missense mutations in pheochromocytomas in patients with VHL who have a complete deletion. We've not yet seen a patient with a complete deletion have a pheochromocytoma. We made tomorrow, but we haven't yet. And patients with a partial deletion of the VHL gene in these families, very much more attenuated pheochromocytoma phenotype. In other words, occasionally we'd see patients in their 30s with a pheo, but very different than the missense mutations and patients who have a characteristic we call pheochromocytoma predominant. Those patients are at risk for early onset bilateral multifocal and extra-adrenal pheochromocytoma. And with Bert Zabar and Michael Lerman and Frida Latif, a whole bunch of wonderful people that we worked with over the years, described types. This was back in 1995. We described type 1 and type 2 VHL and showed that the type 1s, which did not have pheochromocytomas, were more, nonsense, frame shift deletions, whereas the ones with pheochromocytoma, the type 2 VHL, 96% at the time, we found with missense mutations. And we continued that later and expanded that. And then looked also with the VHL patients, we saw some very distinct catecholamine patterns. And in a series of studies defined the quote best biochemical test for diagnosing pheochromocytoma and discriminating VHL pheochromocytoma from other types of pheochromocytoma. And again, from these patients and their tumors, I just can't say enough about these brave people. Learned, got a lot of indications about what the genetic basis this might be. We're able to identify hypoxia signals there, to see that more HIF2 phenotype in VHL pheochromocytoma. And then we, again, these wonderful, brave people that we work with, I'll never, as long as I live, forget a lady we were managing since early experience, came up from the South, and she had a bilateral adrenalectomy. Now, that is the way we all manage pheochromocytomas. We took out the adrenal gland. And this brave woman had a bilateral adrenalectomy in the 80s, before we saw her, actually. And we were managing, she also had a very aggressive kidney cancer phenotype, and we were managing her. And we would do our open surgical procedures. She had no adrenals, and we weren't quite as good then as we are now, probably managing patients with no adrenal tissue, with no adrenal hormones. But she had such a hard time with those procedures. And I said to our team, I said, we've got to stop taking out these adrenal glands. And so we then developed a number of approaches. One is how to manage multiple tumors in these patients, and do we do a single operation and do kidney, theo, and pancreas, and with a number of wonderful people, including Steve Labuti and others, and general surgeons and others, we came up with an approach that we thought it was, quote, safe, unquote, to manage the kidney and the adrenal at the same time, but probably not smart to do a pancreatic tumor resection at the same time. And so that was a bit our approach. And then in the late 1990s, we developed an approach to not take out the entire adrenal gland, to do a partial adrenalectomy. And I will say, in our field, we took a lot of gas about, a lot of criticism about that. Marston, you can't do that. That's not safe. You need to take out the entire adrenal gland. These people could have recurrent disease. They could be at the dentist and have a stroke or something, and it will be your fault. Well, I said, look, we're following these people. We're going to manage them. I don't think so. So we started doing partial adrenalectomies on these patients. And then we showed we could do partial adrenalectomies even with multiple tumors. Well, again, we left a lot of scars and things with our open procedures. So we started doing laparoscopic pheochromocytomas. And my mentor, who's a wonderful colleague, it still is my mentor, helped me get this job at NIH way back in the early 1980s. And I mentioned him, we were going to do we're going to try a laparoscopic adrenalectomy. And he said, Marston, you can't do that. Don't do it. That'll be a disaster. And he said, you can't do a pheo that way. Well, we did, and started doing laparoscopic minimally invasives, and then expanded our experience with that. Showed the management of pheochromocytomas in the pediatric population. And then, again, with Peter Pinto's guidance, developed a robotic partial adrenalectomy approach where we can do these much more minimally invasive now and be much easier on these patients. And this shows a bit how we do that. And this is the kind of thing, for those of you who aren't surgeons, that we've been able and honored to participate in the management of these brave people. And then, again, showed that the functional oncologic outcomes we showed with 5 years of follow-up. And then more recently, Mark Ball just published a couple of years ago the long-term functional oncologic outcomes of partial adrenalectomies, and that it offers excellent oncologic and functional outcomes for most patients, keeping them off lifelong steroid replacement therapies. Another thing we started doing a number of years ago, again, people thought we'd lost our minds, with VHL pheochromocytomas. Why do we have to remove them when they're small? Why don't we watch them? And so we developed an approach and published this last year. Tom Sanford, Adam Wally put this together with the patients with a median follow-up of nearly 17 years, in which our management approach is active surveillance is a safe strategy for management of VHL-associated pheochromocytomas in patients whose tumors are smaller than 2 centimeters. So, we have learned a lot, and again, these brave, wonderful patients have enabled us to make these contributions to their management. And we know also that these tumors can be malignant and can metastasize. And over the years, with these patients with these pancreatic tumors, which have been such a significant source of morbidity for these patients with the multiple tumors. And of course, they, as you all know, they can also sometimes get pancreatic exocrine insufficiency, which is a real difficult thing for these patients with multi-system disease. And of course, we have to stay on top of these. And you're going to hear more this meeting about this, which is great, because we obviously want to prevent this. We want to prevent metastasis. Over the years, we've had a number of patients develop metastatic disease, but fortunately, we're getting better and smarter in how to manage that. We've been blessed with the most wonderful colleagues from surgical oncology, endocrine oncology. We started with Jeff Norton way back when, and over the years worked with Steve Labuti, Dave Bartlett, Richard Alexander, Jim Pinkpank. Electron capability you're going to hear from. Great surgeon, obviously, Deval Patel, our current, at the NCI, our current colleagues. We're just thrilled and honored to work with Naresh Nilabul and Samir Sadowski, who are such wonderful endocrine oncologic surgeons. And over the years, of course, the brain and spine manifestations of these wonderful patients. And I will always, my entire life, be thankful to our neurosurgical colleagues. Again, you're going to hear from them at this meeting. But when I first started seeing VHL patients, I went and saw my colleague, Ed Oldfield, who was the chief of neurosurgery here at the NCI at the time. And I said, Ed, I want to manage these patients. People told me I can't do it here at NCI. It's too complicated, too many diseases, too many systems, and that's not something we could do in NIH. I want to manage it. We want to discover, try and find the gene and develop therapies for this, but I need your help. And Ed Oldfield, I will always appreciate. He said, Marston, I'll help you. And he started managing these patients. We worked with him for over 20 years. And his colleague, Russ Lonser, who then became chief and for 5 years. And then after Dr. Lonser left, Prashant Chidavonia, our wonderful colleague, we've been working with for over 10 years to manage these patients with CNS, spinal hemangioblastomas, and the procedures that they've performed to help these patients with this. And again, for those of you who aren't surgeons, if you look at this one screen here, this has always been our kind of go-to thought about the VHL pathway, and that is angiogenesis, of course, as you all know. And another manifestation of these patients, again, is, of course, the manifestations in the eye, obviously. And we have been blessed so many years with our wonderful colleague who's been by our side to help manage these patients, Emily Chu and Henry Wiley, who's no longer at NCI, but just incredible ophthalmologic surgeons, and who have done 6 trials trying to develop therapies for patients with VHL-associated retinal angiomas. And you'll hear in a minute, and of course you'll hear in much more detail during this meeting about the wonderful result that we're seeing targeting HIF2 in these patients. And as you know, these patients, in our experience, it's 10%, can develop these inner ear manifestations, the endolymphatic sac tumors. And we started with, of course, with our neurosurgical colleagues, but also ENT and Robert Leibovitz, and currently, of course, Jeffrey Kim. So Bert and I wanted to study VHL to see if we could identify a gene, but I showed you the loss of heterozygosity, LOH, loss of a segment of chromosome 3 in tumor tissue from patients with sporadic kidney cancer. We didn't know if VHL was also on chromosome 3. There was some data that it was, but we I removed these kidney tumors, and we would look with Bert to see if there was a loss of the second allele like there was in sporadic clear cell kidney cancer. And of course, that's exactly what we found. But what this was RFLP analysis, and I very few people in the audience know that much about this. This was in the middle 80s, is the way we did this. And then you had to have polymorphisms to find loss of heterozygosity, to find essentially loss of DNA at a location. And so we could tell which allele came from which parent. And so what we showed was there was a consistent loss of the short arm of chromosome 3 here in tumor tissue from patients with VHL, but that it was non-random. It was always the same allele. So, we looked at this, and I said to Bert, look, it's always the same allele. So the gene has got to be in this location. So we said, okay, we're going for it. So we then started bringing patients in to the National Institutes of Health, the National Cancer Institute. This is the NIH campus, and this is the hospital, NIH hospital, the clinical center here in Bethesda, Maryland. And we were fortunate to bring patients in. And of course, we had no test or anything. We didn't know who was affected, who wasn't. So we'd bring these patients in, would image the whole family and determine who's affected, who wasn't. And this enabled us, and with Michael Lerman and Farida Latif and other people, Laura Smith, to conduct genetic linkage analysis to localized disease gene on the short arm of chromosome 3. We already knew it was 3 from the work of others. And we confirmed that, and then continued mapping in this location, and were able to genetically narrow the region here. And then we had a number of cDNAs, and this was the 7th cDNA that we pulled out. We called G7. And a colleague, a postdoctoral fellow from Japan, Masahiro Yao, who is currently the chief of urology at Yokohama City University in Yokohama City, Japan, ran the gel. It was a long-term pulse field gel, electrophoresis gel, and we found an extra band, and we knew, and that extra band segregated with the disease in the families. So we said, okay, this has got to be the gene, and we had this in 3 families, and we submitted that to science. And they wouldn't take it. They said, look, there could be another gene in this location. So my friend Bert Zavar said, well, Marston, I told you we shouldn't have submitted this to science. I said, look, Bert, I said, we got to prove this. I'm not giving up. So I called my wife, and it was late at night. I was just at the office. I called my wife. I said, honey, I said, look, we found they sent this in. We got this, I showed you the data. I said, but science wouldn't take it. And Bert wants to just submit it to some other journal. And I don't want to. I said, I want to work to find this, the sequence and this, that, and the other. And my wife said to me, honey, if you're not going to resubmit that to science, she said, don't come home. I said, okay. I said, I'm with you. So anyway, so we got working on this, and with Bert and Michael and Farida, and started sequencing, and sequencing took us a little while. They gave us a certain period of time, and we got it back in just under the deadline, and of course showed the 3 exon gene, as everyone knows, and mutations that segregate with the disease, of course. But when we at this time, and just for 5 or 6, 7 years, we had pathogen. We're going to use the word pathogenic variation, of course, in this gene, but only in about 2/3 of the families. And again, we have learned so much from these brave people. We saw a patient one week in the clinic, and his family brought him, and he had been hospitalized, institutionalized for a number of years, and he'd been involuntarily admitted to a sanitarium, to a hospital, psychiatric hospital, because he was acting so strangely. And they changed psychiatrists, and a new person got a brain MRI. He had a CNS tumor, a manioblastoma. And turned out he had VHL, and they ended up sending him to us. We ended up seeing that man, and the people in his family who had VHL, but we didn't find a variation in the gene by sequencing. And I'll never forget a conference. We started thinking. We said, "My word, the gene could be lost, could be gone," and that maybe is why we're missing it. I know it's obvious today, but at the time, we didn't know that. And we worked with Kathy Stoley up at Penn, and we developed a way to do southern blots and to look at intensity to show there was loss. We call this quantitative southern blot, and we published this, and we're able then to get our pathogenic variation status up to about, I think, 96 or 97% at the time. And have been able to identify alterations in these families, these wonderful people. And we find, the alteration of the gene, missense frameshift nonsense in about 65%, deletion in about 30% in our experience, about complete deletion, which that family was about 7%, partial 23%, and splicing alterations in about 5%. And I want to show this. This is wonderful work of a colleague, and we've been looking for this for years, but we hadn't found it. We'll talk in a minute about VHL targeting a binding along in C, B, and COL2 in a complex, of course. But this remarkable paper that our colleague, who was one of the senior people on the discovery paper, and that is Eamon Maher, and published this. I'm sure you all saw this, but it just blows me away. This protein here, we additionally identified this with Ron and Joan Conaway, the Longan C. Then it went by the term TCEB1. Now it goes back. Now it's back to ELOC. And he had a family, didn't have a VHL. pathogenic variation. And what they had was a pathogenic variation of a Longan C. And this family has classic VHL with the phenotype that you would imagine, the pathologic phenotype, pretty amazing. This is another type of hereditary clear cell kidney cancer that's VHL associated. That's not von Hippel-Lindau, though. This what we've learned from these families have helped so many other people. These patients can present with bilateral multifocal kidney cancer with solid tumors and cysts in their kidneys. And of course, they have a germline translocation of chromosome 3. And we've learned from our work and work of others that of course, these patients are characterized genetically by translocation of chromosome 3, where the VHL gene translocate goes to, in this family, chromosome 8. And then the second hit, and this was shown by Laura Smith and Bert Zabargash in '94, deletes the whole chromosome 8. We call this a 3-hit model. And the third, quote, hit is a pathogenic variation. In this case, you could use the term mutation of the gene in the tumor, and that causes a clear cell kidney cancer. So this is not a variation germline, of course, but somatic, but it's of course the VHL gene. This is another form of hereditary clear cell that in this work we did with our colleague James Bruderolov at Texas Southwestern, who's been such a pioneer in helping us all understand this gene role. I'll show you. And these patients, this family we had, this patient, bilateral multifocal disease, multiple tumors, fast growth on this kidney cancer. These are all clear cell, no pathogenic variation germline of VHL, but that sure looks like VHL in the kidneys anyway. But they got kind of high-grade kidney cancer, but they also had cysts, just like VHL. They had tumors that grew inside cysts, just like VHL. But this turned out to be BAP1, germline pathogenic variation. And the germline alteration is not VHL. However, in these tumors, just like in clear cell kidney cancer, you almost always see VHL as well as BAP1 mutation in the tumors. And so it appears that VHL is cooperative with BAP1 in these tumors in causing kidney cancer. So you have 3 inherited diseases where VHL is very, very important. And of course, we wanted to see, was this the gene we'd looked for so long in the non-hereditary and clear cell kidney cancer? And obviously, we of course looked at the mutation and deletion and found that in a high percentage of tumors. And with Mike Nickerson and Lee Moore showed that in the most intensive study we've actually done with, I think, 400 tumors or so, looking very carefully, Mike and Lee found mutation of VHL that Maria Marino had looked at and said her clear cell kidney cancer. In 83% of those were clear cell, and 9% had methylation, which we'd shown a few years before with Steve Balin. You can see in a certain percentage of tumors of sporadic clear cell kidney cancer. You can also see methylation sometimes as the second hit, not often, but you can. The second hit in VHL tumors, of course, in VHL. And the other thing that we learned from the VHL population, of course, from these families, from these wonderful patients, we talked about VHL and Longan CB. And in the TCGA experience, cancer genome atlas experience, we found some mutations here, but it was really Sato in an elegant Nature Genetics paper in 2013, who showed mutation of a Longan C TCEB1, we now call ELOC, in 4% of sporadic clear cell kidney cancers. So it's not technically the VHL gene, of course, but it's the VHL pathway in those, a little bit like RBE2F, as I'm sure you can imagine. And then, in the old days, we know Bert and I, we didn't, we said we want to find the quote kidney cancer gene, which we of course saw in VHL, in clear cell, kidney cancer. But then we didn't find it at all in those days in type 1, PAP, type 2, chromo, onco. And then we came to understand, of course, that there was all these different types of kidney cancer with different genes of kidney cancer. And I think as Dr. Kim mentioned so elegantly, that VHL has been the Rosetta Stone for understanding everything And we now are up to 18, soon to be 19 kidney cancer genes, 14 of which, it just blows me away, 14 of which run in families. So VHL taught us so much, not just about VHL, but about kidney cancer in general, and I think really cancer in general. And of course, we learned from those tumors that we took out, they had a mutation and a loss, and we would take cell lines, grow them in a mouse, make a tumor, put a single copy back in, of course, and not get tumors. And then in the Cancer Genome Atlas, with 300 of the smartest people I've ever met in my entire life, we're able to see, of course, VHL, but then a number of other genes. We called them SMGs, significantly mutated genes. And of course, there were a number of studies besides TCGA showing this, and TCGA wasn't the first to show it, obviously, but we did show it very intensively. And that other genes, PBR1, SETD2, and BAP1, which are on chromosome 3. And of course, in the VHL, and you're going to hear at this meeting, some very elegant work about looking at these other gene mutations in tumors from VHL and what we're learning about that, maybe affecting growth rates and all sorts of things, and maybe response to therapy, and we'll see. And then, of course, we wanted to know how this gene we found in these families was, how'd it work? We wanted to, people said to me, gee, why don't you start working on lung cancer now? You've learned all this genetics. I said, no, we want to develop therapy for these patients with VHL. So we showed that VHL binds with Bill Kalin, showed that VHL binds two proteins. And Roxanne Duane was the postdoc in my lab working with Rick Klausner in his lab. And we showed these two bands that came down with VHL and called Alongin C and Alongin B. And we published this in Science, and we were so happy about this, but it still didn't help us understand how this worked. And our group, and of course, Bill Kalin's group, and Othon Eliopoulos was first author on this paper, we all know, our colleague, showed that VHL seemed to have negative regulation of hypoxia-inducible genes, oxygen genes. And then a couple of years later, and this is with the colleague who was in Rick Klausner's lab, and who now is an incredibly accomplished scientist in Canada, who took out this band here and sequenced that. And that was COL2. And we showed that VHL complex bound COL2 as well. And we could look at the yeast, and this was Arnhem Pause, and we could look at yeast and understand that this looked very similar to what they called F-box protein, which was a ubiquitin transfer enzyme complex. And we hypothesized with this work, it's possible that this is a degradation complex that targets transcription factors that regulate the stability of hypoxia-inducible RNAs, such as VEGF, PDGF, GLUT1. In other words, very shortly after that, Peter Radcliffe, and then Bill Kalin, Dr. O, showed that the VHL complex targets hypoxia-inducible factor in a normoxic fashion. In normoxia, targets HIF for degradation, but does not in hypoxia. And for this, and then 2 years later, the Kalin group and the Radcliffe group, their landmark study showing that it's prolyl hydroxylase, which is the mechanism for oxygen sensing. And of course, in 2019, were awarded the Nobel Prize for this work on how cells sense and adapt to oxygen availability. Well, we also, of course, this pathway has also, of course, been used to develop a number of therapeutic approaches for patients with advanced kidney cancer. And a number of groups, including the John S. group and at MD Anderson, our group with Ramsden as PI, did a number of trials evaluating drugs in the VHL population. And with a drug called vandetanib, which is no longer available, Ramsden saw some dramatic response targeting these patients. But the problem was the drug's too toxic, and it was very hard to get these patients interested, which completely understood. And in 2002, the Kalin group, our group played a role also, showed HIF2 is a critical pathway in the VHL kidney cancer pathway. And we and others were trying desperately to find agents, and we published one or two things, agents targeting this pathway, but it was the landmark work of Rick Bruick at Texas Southwestern. He's a friend of my wife's, actually, who's a great scientist, and he developed a drug, a way to do it, developed a drug that would target HIF2. And then the Brugarellis group and the Kalin group published 2 landmark papers in Nature showing this drug, which targeted HIF2, had activity in kidney cancer in preclinical models. And they contacted us and asked if we would be interested to look at this agent. Ramsden ran a trial with a precursor drug called 2385. And then they came out with a better drug with more activity and became a multi-center trial. Number of colleagues, Eric Yonash, everyone knows, of course, and Othon Iliopoulos, a number of colleagues conducted this trial. Ramsden was the PI at NCI. And you're going to hear a lot about this at this meeting. It's incredibly exciting data. My knees are still weak when I see patients who are on this drug. And you'll hear all about the incredible responses being seen in kidney cancer. Who knew? In CNS hemangioblastomas, real objective responses, 44%, 52% stability, real responses. You're going to hear about pancreatic neuroendocrine tumors. We had no idea we'd see a response there. The preclinical work we'd all done been on kidney cancer. We hope so. I thought we might. Who knew you'd see these kind of 90% responses in pancreatic neuroendocrine tumors? And Emily Chu, my friend, our colleague, ophthalmologist, and Henry Wiley, just astounded. They've worked with us so many years on these patients to help with their eyes, and they did so many trials to try and treat the VHL-associated retinal angiomas, injecting drugs into the eye and different things, all these wonderful things. And then to see this, they called and said, Marston, we've never seen anything like this. You're going to hear about this again today. And then we're so thrilled on August 13th, 2021, when in the US, the Food and Drug Administration approved belzutifan for patients with VHL. And as you know, there are now very exciting trials, again, all based on what we learned from these brave, wonderful VHL families. And we're able to identify this gene, and all of us work together to understand the pathway and to develop drugs. And we still got a long way to go, But can we use this for prevention? All sorts of different things to think about. But also, how about sporadic clear cell kidney cancer? And we're seeing, and you'll hear from those colleagues, we're seeing wonderful responses in patients with metastatic clear cell. Again, over the years, I've been honored to work with a wonderful group of colleagues in the lab, with our clinical colleagues, our basic scientists. We have a wonderful collaboration we're currently going with Bill Kayla, Dave McDermott, Tony Sherry, working on targeting the VHL-HIF pathway. Our colleague Samra Tradley, Scott Sampson, Watson, other colleagues at the Crick Institute. We're thrilled to have those opportunities. And I want to acknowledge my colleague, Ramsden Linehan, who's been partner and colleague for so many years, who directs our therapeutic trials. My colleague, Mark Ball, one of the most gifted urologic surgeons I've ever had the honor to work with. My other colleague, Sandeep Garan, who's more recently joined us as a urologic oncologic surgeon, helping manage patients with von Hippel-Lindau. my long-term colleague, Peter Pinto, who really helped us pioneer minimally invasive approaches for these brave and wonderful patients. My colleague, Maria Marino, who I've worked with over 30 years and was by our side with every single patient and still is to help us understand what we're seeing in these patients, in their tumors, and help us think about our clinical management and surgical approaches. More recently started working also with her colleague, Antoine Tubajic, and our colleague, Ashkan Malieri, the most wonderful radiologist, physician scientist I've ever had the opportunity to work with. And I've worked with a lot, including Peter Choyke, Brad Wood, who've also been just incredible colleagues, and the entire urologic oncology program. And I can't say enough about the brave and wonderful patients that we have had the honor to work with over the past 38 years. These brave patients with VHL. And I have heard so many times from these wonderful people, they would say to me, Dr. Linehan, I don't know if you're going to be able to help me really, but this may help other patients with this disease and may help my grandchildren or my children. I've heard that so many times. And last week I saw a patient in clinic and she said to me, Dr. Linehan, she said, you told me in 1993 you were going to find a drug for this disease. I said, well, it's not me, it's a whole group of people working on this, but I've worked on it, that's for sure. And I said, but we still have a long way to go, but we're making progress and science works. And it's because of you that we've been able to do this. So thank you very much. And thank you to those wonderful, brave people. Thank you.
Thank you, Marston, for a wonderful, wonderful talk. We do have some time for questions. So I'm going to first thank you again for sharing all this work, and we truly stand on the shoulder of giants such as yourself and your colleagues. Being in VHL work for over 30 years, it sounds like, what do you think the future holds in store now that there is a good therapy, promising therapy on the block? What do you think is going to happen in the next 30 years, or what do you think envisions?
Oh, well, I think we'll learn from each other, but I think that we have a whole lot of work to do, but an exciting life. I mean, I think to decide, needless to say, we want to go for complete response in every tumor. We want to go for prevention, of course. So we want to be able to come up with a drug. We give 10-year-olds or 8-year-olds, and we all know that. What do I personally think? I think that we're gonna, together figure out which tumors respond, which don't. We're gonna hear some exciting things at this meeting about that. Which tumors respond, which don't. And also, are we going to need combinations of drugs? I suspect that'd be the case, and we'll just have to see. There's other HIF2 drugs, I think, coming out as well. But we're doing so well with this agent. I mean, it's just so exciting. And how long can we keep people on it? Could we go to a lower dose and go on longer? How can we think about prevention? What can we do with imaging, with AI? You can imagine all the exciting things you can do. With AI, we'll be able to predict which tumors will grow at which rate. We'll be able to intervene earlier, intervene smarter. I mean, is it ridiculous to think about a future world where with AI, we could look at tumors and say those in a patient that's got 5 renal tumors, we'll say, those 4 are going to respond, that one's not. Go in robotically, take that out, and then put the patient on therapy. Will that kind of thing be possible? Will that make sense? I think so. I think another thing, and again, I'm really excited to see some of the posters and everything. In other words, something we've not touched yet, but obviously it's a huge area. What's the role of the immune system in all this? What's the role of the immune system in the growth of these tumors? I mean, I think we're going to look back and think we're doing now is primitive, looking at growth rates and things, obviously. When in 2012, there was a paper that came out in New England Journal of Medicine. and it was the elegant study of Charles Swanton and his colleagues, in which they had 3 patients with clear cell renal cancer. And they showed something that surgeons know, but they proved that these are heterogeneous. And they had different mutation patterns in different areas, clonal expansion and that. And of course, they followed that up with that incredible Cell paper, and I think it was 2014, and expanding that work in patients. But when that paper came out, I was contacted by Dr. Francis Collins 20 minutes later. And the question was, what do you think? What's this telling us about cancer? Of course, the NIH NCI had been at the time doing this large cancer genome atlas study where we looked at single sample from tumors, of course. So what does this mean? What does this mean for therapy and all? 20 minutes after that, I was contacted by Dr. Harold Varmus. Dr. Varmus, Nobel laureate, was director of the National Cancer Institute. Marston, what do you think about this? And that night I said to my wife, Tracy, I said, well, honey, Charlie Swanton did this beautiful paper in a journal today showing heterogeneity, something a surgeon knows, but he proved it and showed different clonal expansion. And Francis Collins talked to me about that, and so did Harold, Dr. Varmus also. Dr. Collins, Dr. Varmus. And she said to me, well, what'd you tell him? I said, oh, honey, it's kind of complicated. I said, it's, I don't know. She said, it's not complicated. You know the answer to this. You've already explained it to me. I said, what do you mean I'd explain it to you? She said, honey, you've already explained it to me. You know what the future is going to be, right? This was 10 years ago. I said, yeah. She said, yeah, it's going to be imaging, right? You're going to be able to look at that imaging, and you're not going to care what genes you mutated. You care about pathways and therapy, right? You're going to be able to see that in imaging. Well, I think she was right. Anyway, so I think that with VHL, that imaging is going to play a huge role in our understanding of this in the future. I think also, I think it's going to be, though, I think it's going to be a tough road. I think we've got a ways to go, though, to improve on where we are. I think we're going to have to learn a lot about HIF, about this marvelous drug, belzutifan, when to use, where to use, how to use, all that. It's just all sorts of things. How about FEO? Obviously, everybody's interested in pheochromocytomas. If you have a mutation of HIF2, what do you get? You don't get clear cell kidney, you get PHEOs, right? So that we want to know about, obviously, a whole lot of things, but I think that combinations and the role of the immune system and the genomic basis of resistance and response, I think it'll be the next 10 years.
Thank you, Marston. I do think the immune system is a critical component, and just while I have the ear of this intelligent crowd is, some of the movement in other hereditary cancer syndromes is to come up with a cancer vaccine that we have learned a lot from the COVID work. And as soon as we know how the immune system is playing a role in VHL, perhaps even a vaccine can be designed with mRNA technology and that type of thing. I'm going to turn it over to Michael O to see if he has a question. Hi, Michael.
Hi, Marston. Wonderful talk, very inspirational, quite admirable. Thank you for that. I didn't have the pleasure of meeting you in the past, but I'm glad to meet you, albeit virtually, so thank you.
I've been following your work for years.
Well, I've been following your work even longer.
The O word. OHH, yes.
There's a quick head scratcher for me. Of course, I've been studying this a while, and it pertains to pheochromocytoma and paraganglioma. As you mentioned, there are HIF2 mutations, and these patients develop paraganglioma and somatostatinoma as well as pheochromocytoma. And the question is, when you have a type 1 VHL disease, there's a train wreck VHL mutation. So I'm assuming HIF2 is upregulated in these patients, that one would expect, but they don't develop, as you said, and we all know, they don't develop PHEO. So I don't quite understand that. I'm sure we're missing something. So I'd love to hear your thoughts on that.
I'm with you. I don't understand it either. And I'm sure, I think we're missing something as well. And I think it's very important. I agree with you. And, and look, there's a whole lot smarter than I am. What's your sense? Let me ask you, what's your sense and what's the data
Mhm.
for HIF2 playing a critical role in fields. We, of course, know from the genetic data, which is
Yes.
incredible. But you know, that you have a mosaic or a germline of HIF2 that
Mhm.
you get PHOs and, you know, polycythemia, pulmonary hypertension,
Yeah.
and I guess duodenal somatostatinomas, I guess you can say. So
Mm. Yeah.
I'll ask you, what's the data on
What-
HIF2 and VHL
Yeah.
being critical?
It is perplexing. Our lab, we've taken sort of a more of a structural route over the last 5-7 years or so. And one of the indication, this is just the theory at the moment. So when we look at PHD2 driven disease or HIF2 driven disease and the different phenotype they receive, one could segregate using just threshold of HIF2 activation. So more HIF2 activity, you get a certain phenotype, less HIF activity, you get the lesser kinds such as polycythemia. So going back to type 1 versus type 2 VHL disease, one thought is that maybe the missense mutations that you see in PHO for VHL patients, perhaps there's a certain threshold level of HIF2 that needs to be activated, but too much might be incompatible with the neuroendocrine cells. So basically progenitor cells, but so maybe they don't basically survive. So you never see that scenario. So that is the only hand waving answer that I can sort of come up with. So basically in type 1, train wreck mutation is too high and those progenitor cells, they just never make it. So there's basically a culling of these PHO cells early on.
Wow.
Not just hand waving, but that's the only explanation I could sort of come up with. I have no proof of that, but yeah.
Wow, that's incredible. I never would have thought of that. Let me ask you the following question. Do you think that, like with a missense, you could have partial function of VHL?
Yes.
You've got a solitary allele, but enough to make a tumor, maybe, but I mean a kidney or something. But
I think so.
what do you think?
I think so. That's exactly it. That's exactly it. Of course, the reason why I don't see HIF2 driven disease patients having RCC is probably because of all those other genes that are important for RCC that you've mentioned, along C, BAP1, maybe even interplay with HIF1. So therefore, HIF2 driven disease, you would never see that, the HIF1 inactivity at a certain point in the progression of kidney cancer. So I think there's something there as well, but anyways, it's been a bit of a head scratcher.
Can I ask you one other question? Well, I've got, and that is, what's your sense? You know, we all learn from Bill Kaelin. You know, I mean, that we just do, and you know, that's it. What's your sense about role of HIF1?
Okay, so I'm sure Greg Semenza will weigh in on this quite a bit as well. Kidney cancer, for kidney cancer, I do think that a HIF1 loss or inactivity earlier on is probably important for RCC development. So the involvement of HIF1 in other phenotypes in VHL disease, I think it could be relevant. So again, just looking at the sort of the rheostat model of HIF1, HIF2 activation and its activity in various phenotypes might be important for kidney cancer. I think it's the opposite. I have a feeling it is the involvement of HIF1 earlier on in the disease onset, but then at some point, its activity must disappear or be diminished. So I think this is why you see sort of a loss of HIF1 expression as the disease progresses in RCC. That is my understanding of it. So I think it's that interplay between HIF1 and HIF2 that I think is important. But from my standpoint, HIF2 clearly is a driver of a lot of things that I'm seeing. So I think this is why we're seeing such a tremendous effect with belzutifan and such promise. I'm very excited about that as well. Yeah. But it is definitely, we clearly don't understand everything, obviously, but it is fascinating, absolutely fascinating.